And we're live with William H. Murray, the INFRAGARD editorial, and today Bill is going to be talking about Hipaa. All right, and we'll let Bill get into the bits and pieces on that one. All right, Bill, why don't you go and take it over?
Joe, Hipaa is in the ditch. It's an understatement to say that Hipaa has had unintended consequences. In fact, it has had perverse consequences. The Hipaa privacy regulations were intended to encourage electronic medical records, in part by addressing patient and physician concerns about the leakage of sensitive medical information. After almost 2 decades, in what is now the largest and fastest growing segment of our economy, medical records are still the least automated records of any industry. The insurance companies and large research hospitals are pretty much automated. However, primary care physicians and regional hospitals are hardly touched at all. By one estimate, only 15% of medical records are automated, a number that the banks, another sensitive industry, had achieved 40 years ago. What is worse is that even those that are electronic are not integrated in any meaningful or useful way. In retrospect, this well-intentioned law was flawed from the start. First, Hipaa applied to electronic records, but not to paper ones. The concern was that electronic records would leak information faster than paper ones. On the other hand, the problem with paper medical records is that they are isolated, incomplete, and error-prone. The result is that medical care is inefficient. That's the primary reason that we ought to automate. However, rather than encouraging the automation of medical records by imposing privacy and security requirements on electronic records that do not apply to paper, Hipaa has had the perverse effect of discouraging automation. The Hipaa requirements are dated. They were developed a generation ago. They were developed in the era of large, scarce, and expensive storage. They were developed before the dramatic deflation in computer prices, before small computers, much less those small enough to be carried in one's pocket. They were developed before the deflation in communication costs, before the World Wide Web, much less cellular broadband, Wi-Fi, and Bluetooth. The requirements included many exceptions for the very uses of the records that most concern patients. While each of the exceptions can be justified, collectively they damage the necessary public trust and confidence. At the end of the day, if the patients and doctors do not trust the electronic system, it simply will not only will it not work, it simply won't be used. It won't even come into existence. With the best intentions, the authors made the regulations risk-based. They told the covered entities to do a risk assessment and then to behave accordingly. They did not want to be too prescriptive, and perhaps a generation ago they shouldn't have been. We didn't know then what we know now. In addition to the fact that risk assessments are expensive and require knowledge, skills, and abilities and experience that only the largest covered entities possess, they don't tell you what to do. They tell you what your risks are. They may tell you how much security can be justified. But what they do not do is tell you what security measures you ought to employ. The fact is that risk assessments and the requirement thereof have incapacitated the average physician and the average regional hospital. One implicit assumption in all of this is that the risks are different for each entity. Therefore, each entity has to do its own risk assessment. While the risks are different for each class, that is, they are different for a research hospital than they are for a diagnostic clinic like Ochsner or Mayo, or different from a regional hospital or a large primary care practice. Within a class, the risks are very similar. At least to the extent that we can measure and plan, my doctor's risks are the same as your doctor's risks. We should be sharing risk assessments within a class, not replicating them across the class. Then there's fraud, waste, and abuse. In reverse order, abuse of patient records begins with government, goes through the covered entities, and through the clinicians. Nurses seem to believe that talking about patients is essential to their own mental health rather than abusive gossip. In the absence of electronic records, we duplicate and replicate tests and treatments. We call that waste. In medicine, waste is endemic and systematic, not to say institutionalized. Fraud in medicine targets Medicare and the insurance companies because that's where the money is. However, you and I are the ones that pay, and we are key to resisting it. However, by the time we see the confirmations of services and charges, we can no longer even remember what happened. We have learned that email confirmations of financial transactions and online review of our accounts are powerful mechanisms for resisting fraud, and yet we don't use either of those in medicine. While paper records may be superior to electronic ones in resisting change, electronic ones are superior in resisting abuse by reporting access, legitimate or otherwise. We have all kinds of abuse of medical records where people are sitting, you've all heard it. You've all heard the ones about people going in and looking at the medical records of celebrities, in large part because looking involves no accountability. In February 2009, as part of the Economic Recovery Act, the Obama administration passed the High-Tech Act, ostensibly intended to encourage conversion to electronic records. However, while there are incentives in the law for doing so, enforcement under the Act punishes abuse of the records, not failure to automate. You think I exaggerate? Go out and look at the HHS website and look under enforcement of high-tech. It's scary. You know, I wouldn't want any part of being covered by that law. Finally, there is the focus on the cost of compliance. Every physician seems to have heard the estimate that the cost of converting his medical records to electronic patient records and practice management systems is $30K. None of them seems to have the foggiest idea of the benefits to their practice, or even the time frame that cost can be spread over. Now, this might not be important if people weren't dying as a consequence of relying on incomplete and erroneous records. It might not be important if the most expensive service in our society were not also the most inefficient. There are few things in life more dangerous than legislators with good intentions. Few things more difficult to remedy than bad law. However, in this instance, the counterproductive measures are mostly in regulation, not in the law. They ought to be easier to rationalize and to fix. It's time for us to recognize that the regulatory approach has failed. Its impact has been worse than any of those that it was intended to resist. Good security practices for the typical regional hospital or the private medical practice are not expensive. What's more, we know what they are. They do not need expensive risk assessment to identify or justify them. Let's get on with it. Thank you, Joe.
Thank you, Bill. We certainly appreciate it, and